If you search how to activate your stem cells right now, you'll find hundreds of supplements, clinics in Mexico and Thailand, and treatments that cost thousands of dollars. Most of it is pseudoscience. But here's what's interesting. That doesn't mean there's nothing you can do, because the real research published in Nature, Cell Stem Cell, and the New England Journal of Medicine shows there are at least 4 accessible interventions, most of them free, that have demonstrated measurable effects on how your stem cells function after 65. And in the last 5 years, something shifted in this field. 3 separate research teams at Stanford, MIT, and Mount Sinai published findings that genuinely changed how scientists think about aging stem cells. Not in a "we cured aging" way, in a quieter, more precise way that I find far more credible and far more useful for people like you. My name is Dr. Becker. I spend a significant portion of my week reading primary research so I can translate what actually matters into language that helps people make real decisions about their health. What I'm sharing today comes directly from peer-reviewed studies, and I'll be specific about which ones, what their limitations are, and what we can reasonably conclude. That's a promise I make on this channel. Before I go further, I want to be clear about something important. What you're about to hear is educational information based on current scientific research. It is not a substitute for personalized medical advice. If you have existing health conditions or take medications, and I'll be specific about which ones matter for today's topic, please talk with your physician before implementing any of the interventions we'll discuss. Some of them have real interactions that you need to know about. Here's what we're covering today. I'm going to walk you through what actually happens to your stem cells after 65, drawing on 5 documented biological mechanisms that the research now explains with real precision. Then I'll show you the studies that suggest these mechanisms can be meaningfully influenced by things you do every day. And then I'll give you a practical protocol, 5 pillars organized by strength of evidence, so you leave this conversation knowing exactly where to start. If this kind of evidence-based health content matters to you, subscribing to this channel helps me keep producing it. No pressure, I just appreciate you being here. Let me start with something that reframes the entire conversation. You've probably been told that aging is mostly about cells dying, that your body just runs out of the raw material it needs to repair itself. That picture is incomplete in a way that turns out to be clinically important. The more precise story is this. At 65, you still have most of the stem cells you had at 25. The problem is not that they've disappeared. The problem is that they've largely stopped working. And the reason they've stopped working is something researchers now call the toxic aging environment. Think about what stem cells actually do. They are your body's maintenance crew. When a muscle fiber tears during exercise, stem cells in that muscle, called satellite cells, wake up, divide, and repair the damage. When your blood cells wear out, hematopoietic stem cells in your bone marrow produce replacements. When the lining of your gut needs renewal, intestinal stem cells handle it. This process runs continuously, invisibly, throughout your life, and between the ages of roughly 60 and 75, it slows down in ways that have cascading consequences. Ones that used to close in days take weeks. A respiratory infection that knocked you out for 2 days at 40 now takes 10. Muscle mass erodes despite the fact that you haven't changed your habits. Bone density drops. Immune response to vaccines weakens. These are not random bad luck. They are in large part downstream effects of stem cell dysfunction. And the research of the last 5 years has gotten specific enough that we can now talk about the mechanisms in detail. There are 5 of them. Understanding all 5 matters because each one points toward a different intervention. They don't operate in isolation. They interact, and when you understand the interaction, the protocol I'll give you later makes a lot more sense. The first mechanism is the one that gets the most attention in the literature right now, and for good reason. It involves what scientists call senescent cells. And if you want a mental image for what they do, here it is. Imagine a renovation factory. Your stem cells are the young workers trained, ready, waiting to be deployed. But the factory floor is crowded with retired workers who refuse to leave. Worse, they're not just standing around. They're shouting constantly. They're issuing contradictory orders, creating noise and confusion that prevents the active workers from doing their jobs. That's what senescent cells do. They're cells that have accumulated enough DNA damage or oxidative stress that they should have undergone apoptosis, programmed cell death, but instead they get stuck. They stop dividing, but they don't die. And in that stuck state, they begin secreting a cocktail of inflammatory signals called the SASP, the senescence-associated secretory phenotype IL-6 TMF alpha IL-1 beta matrix metalloproteinases. These signals were originally designed to call the immune system to clear out damaged tissue. But when the cells secreting them accumulate faster than the immune system can clear them, which is exactly what happens as we age. Those signals become chronic. They poison the local environment that stem cells live in. The technical term for that environment is the stem cell niche. And the critical insight from the last decade of research is that stem cell function is not just about the stem cells themselves. It's about the neighborhood they live in. A healthy stem cell placed in a toxic niche will underperform. A struggling stem cell placed in a healthy niche can recover. This changes the entire framework for intervention. In 2019, a team at the Mayo Clinic published the first human clinical trial demonstrating that senescent cells could actually be reduced in living people. The study by Hickson and colleagues in EBO medicine involved 9 older adults with diabetic kidney disease. They received a short course of the satinib combined with quercetin-2 compounds with senolytic properties, meaning they selectively eliminate senescent cells. After just 3 days of treatment with evaluation at 11 days, the results were measurable. Significant reductions in P16 positive and P21 positive senescent cells in adipose tissue. Reductions in IL-6 ilone alpha and matrix metalloproteinase, and an 8% increase in the density of adipose progenitor cells. Essentially more stem cell precursors available for tissue repair within 14 days. Now I want to be precise here because this is where I see a lot of health content go wrong. That study had 9 participants, no control group, a specific patient population with diabetic kidney disease. Datinib is an oncology drug that requires a prescription and medical supervision. It is not something you should seek out on your own. This study is not a mandate to go buy anything. What it is scientifically is a proof of concept. It demonstrated for the first time in humans that the senescent cell burden, the toxic load that blocks stem cell function, is not fixed. It is reducible. That's the meaningful finding. I'll come back to what you can actually do about senescent cells later. For now, understand that this first mechanism, the SASP-driven poisoning of the stem cell niche, is the foundation on which the rest of the biology sits. The second mechanism was revealed most dramatically by a 2025 paper from the Icahn School of Medicine, led by Dr. Shaheen Ghaffari. The study focused on hematopoietic stem cells ASCs, the stem cells in your bone marrow responsible for producing every blood and immune cell in your body. What Ghaffari's team found was that aged HSCs had accumulated a specific kind of internal dysfunction. Their losomes, the cellular recycling centers, had become hyperactivated and dysfunctional. Let me explain what that means with an analogy. Every cell has an internal waste management system. The losomes are the recycling plant. They break down damaged proteins, worn-out organelles, and cellular debris so the raw materials can be reused. In young cells, this system runs efficiently. In aged stem cells, something goes wrong. The recycling plant gets overwhelmed. Instead of processing waste, it starts accumulating it. Damaged mitochondria, misfolded proteins, and fragments of cellular machinery pile up inside the lysosome, triggering inflammatory signals through a pathway called CJS-STING. The cell becomes increasingly toxic to itself. What the Mount team did was treat aged ASCs ex vivo, meaning outside the body, with a lysosyl inhibitor to correct this dysfunction. The results were striking. The treated aged stem cells recovered what the researchers describe as juvenile metabolism, improved mitochondrial function, a rejuvenated epigenome, and reduced inflammatory signaling. Their hematopoietic capacity, their ability to produce blood and immune cells, increased more than 8-fold. Ghaffar's comment in the press release was careful but significant. The aging of blood stem cells, he said, is not an irreversible destiny. Now, this was a mouse model, and the lysosyl inhibitors used are not approved for anti-aging use in humans. I'm not telling you this study has a clinical application today. What I'm telling you is what it means mechanistically. The internal recycling machinery of your stem cells is a legitimate target, and there are lifestyle interventions specifically around autophagy, the cellular self-cleaning process, that influence this system: fasting, caloric restriction, certain dietary compounds. I'll connect those dots in the protocol section. The third mechanism explains something that anyone over 60 has probably noticed and attributed to just getting older. Muscle injuries that used to resolve in a few days now linger for weeks. Recovery after hard physical work takes longer. The explanation lives in a protein called cycling D1. Your muscle stem cells, satellite cells, normally spend most of their time in a state called quiescence. It's a kind of standby mode. They're not actively dividing, but they're ready to respond when there's a signal of damage or stress. Cycle D1 is the protein that allows them to exit quiescence and begin dividing. Think of it as the alarm clock. Young muscle stem cells have robust cycling D1 expression. The alarm is sensitive, they wake up fast. In aged muscle stem cells, cycling D1 expression declines. The alarm gets quieter. The cells fall into what researchers describe as a deeper quiescence, a sleep so deep that even strong signals of injury don't reliably wake them. This is one of the primary drivers of age-related muscle loss, what clinicians call sarcopenia. And it also contributes to the extended recovery time from any physical stress. The important finding, the one published by Bread and colleagues in Nature Metabolism in 2020, is that this is not irreversible. The study used mice aged 20 months, which corresponds roughly to 60 to 70 years in humans. One group engaged in voluntary aerobic exercise for 3 weeks. The result? Restoration of cycling D1 expression in muscle stem cells to levels comparable to young animals. The aged muscle stem cells woke back up. They responded to injury signals at near youthful speed. There was a particularly elegant part of that experiment. The researchers took blood from the exercised old mice and injected it into sedentary old mice, animals that hadn't exercised themselves. Those sedentary mice showed the same benefit, which tells you something important. The effect of exercise on muscle stem cells is not only local. Exercise releases circulating factors into the bloodstream. The researchers haven't fully characterized all of them that act as systemic signals improving stem cell function across the body. Your bloodstream when you exercise becomes a pro-regenerative environment. When you don't, it becomes the opposite. The fourth mechanism involves your blood and immune stem cells in a different way. As we age, hematopoietic stem cells undergo what researchers call myeloid bias. To understand what that means, think of your immune system as an army with 3 divisions. The first division is infantry, fast-responding general-purpose fighters. In biological terms, these are myeloid cells, neutrophils, monocytes, cells that produce acute inflammatory responses. The second division is special forces, the adaptive immune cells, T lymphocytes and lymphocytes that learn to recognize specific threats and generate long-term immunity. The third division is the military academy, the stem cells themselves, constantly training and producing recruits for both divisions. In younger adults, the academy produces a balanced output. In older adults, something changes in the command structure. Elevated levels of IGF-1 and a signaling protein called PKA act like a standing order of high alert. Under chronic high alert, the academy overproduces infantry myeloid cells at the expense of special forces. You get more systemic inflammation and weaker adaptive immunity simultaneously. This is why older adults respond less robustly to vaccines, have higher susceptibility to infections, and face elevated risk of certain blood cancers. The stem cells themselves are being steered toward a dysfunctional output by hormonal signals they're receiving from the aging body. Research from Walter Longo's lab at USC published in Cell Stem Cell in 2014 demonstrated that prolonged fasting in the range of 48 to 120 hours reduced IGF-1 and PK signaling, creating conditions where hematopoietic stem cells could in a sense reset. The army stood down from high alert long enough for the academy to rebalance its output. I want to be very direct here. Fasting of that duration is not appropriate or safe for most people over 65 without medical supervision. But this finding is the mechanistic basis for why more moderate intermittent fasting protocols, which I'll discuss in the practical section, have biological logic behind them. The fifth mechanism ties the others together. It's called inflammaging, a portmanteau of inflammation and aging, and it refers to the chronic low-grade elevation of pro-inflammatory cytokines that characterizes the aging body. IL-6 TNF-alpha, IL-1 beta, the same molecules secreted by senescent cells, accumulate in the bloodstream and tissues of older adults independent of any specific infection or injury. They're just there, chronically elevated, creating what researchers describe as a systemically toxic microenvironment for stem cells. The 2023 Stanford study published in Cell Stem Cell from the Paul F. Glenn Center for the Biology of Aging made a finding that I think is underappreciated. Using systematic multi-compartment analysis, they demonstrated that exercise doesn't just help muscle stem cells. It reprograms the inflammatory landscape across multiple stem cell compartments. Simultaneously, bone marrow, muscle, brain. The effect is systemic and the primary mechanism is anti-inflammatory. Exercise done consistently reduces the very cytokines that poison the stem cell niche. This is why the neighborhood analogy matters so much. You could theoretically have perfectly healthy stem cells, but if the neighborhood they live in is chronically inflamed, they won't perform well. The interventions that clean up the neighborhood, that reduce the ambient inflammatory burden, may be as important as anything that acts on the stem cells directly. So those are the 5 mechanisms: senescent cells poisoning the niche, lysosomal dysfunction accumulating internal cellular waste, loss of cycling D1 trapping muscle stem cells in deep quiescence, myeloid bias from elevated IGF-1 and PK pushing immune stem cells toward chronic inflammation, and systemic inflammaging contaminating the entire stem cell environment. Each one of these is a documented biological process. Each one is modifiable, and here is the protocol for doing so. I want to be direct about something before we go into it. None of the lifestyle interventions I'm about to describe have been proven in Phase 3 randomized controlled trials to demonstrably restore stem cell function in healthy human adults. That standard of evidence doesn't yet exist for this area. What does exist is a convergence of mechanistic data, animal studies with strong translational signals, and a growing number of human trials on outcomes that are downstream of stem cell function, muscle mass, immune response, inflammatory biomarkers, physical performance. When I give you these recommendations, I'll tell you exactly what level of evidence sits behind each one, and you can weigh it accordingly. The first pillar, and the one I want to be most direct about, is exercise. If there's one intervention I can point to with genuine confidence, it's this one. Not a supplement, not a protocol you pay for. Aerobic exercise of moderate intensity. The evidence for its effects on the biology we've been discussing is more consistent than anything else in this field. The mechanism is clear from the Bredel Nature Metabolism study and the Stanford Cell stem cell data. Aerobic exercise restores cycling D1 in muscle stem cells, reduces SAS cytoins in the stem cell niche, and releases circulating pro-regenerative factors into the bloodstream. The effect is multi-compartment. The dose that shows benefit in the evidence is aligned with standard public health recommendations. At least 150 minutes per week of moderate intensity cardio spread across 5 or more days, 30 to 45 minutes per session. Moderate intensity means you can hold a conversation, but you're working roughly 50 to 70% of your maximum heart rate, what exercise physiologists call zone 2. On top of aerobic work, resistance training 2 to 3 times per week directly activates muscle satellite cells and counteracts sarcopenia. The evidence base for resistance training's role in preserving muscle stem cell function is summarized in a 2025 Frontiers in Aging review, and the consensus from international sarcopenia guidelines is that older adults need at least as much resistance training as younger adults, possibly more, given the deeper quiescence of their satellite cells. A word on safety, because this matters for this age group. If you have uncontrolled coronary artery disease, severe hip or knee arthritis, severe osteoporosis, or blood pressure consistently above 160/100, please work with your physician before starting or intensifying exercise. Begin at a lower intensity than you think you need to and build gradually. Stop immediately and seek care if you experience chest pain, pressure, irregular palpitations, dizziness, or shortness of breath disproportionate to your effort. The second pillar is nutrition. And here I want to separate two things that often get conflated: the quality of what you eat and the timing of when you eat. Both matter through different mechanisms. On quality, the dietary pattern with the strongest epidemiological association with reduced senescent cell burden and better physical function in older adults is the Mediterranean-style anti-inflammatory diet. The mechanism runs through multiple pathways. Extra virgin olive oil, specifically its oleoanthal and polyphenol content, inhibits FCAPA, one of the central pro-inflammatory signaling pathways that drives CITED. Fatty fish, salmon, sardines, mackerel provides EPA and DHA, omega-3 fatty acids that directly reduce IL-6 and TNF-alpha, the primary SAS cytoins, and appear to support the structural integrity of cell membranes, including in stem cells. Cruciferous vegetables, broccoli, Brussels sprouts, cauliflower contains sulforaphane, which activates the NRF2 pathway and induces autophagy, the cellular self-cleaning process relevant to the lysosyl mechanism we discussed earlier. Berries, blueberries, strawberries, raspberries contain anthocyanins and a compound called fisetin that has demonstrated weak but documented senolytic activity in preclinical models. I want to be precise about fisetin. In vitro data is interesting. There is no RCT in healthy older humans demonstrating that eating berries clears senescent cells. What I can say is that the dietary pattern incorporating these foods consistently associates with lower inflammatory biomarkers in population studies, and the mechanistic pathway is plausible. Eat the berries for a dozen good reasons. Just don't expect them to do what the satinib does in a clinical trial, on protein. Older adults require significantly more than younger adults to maintain muscle mass and support satellite cell activation. The European Society for Clinical Nutrition and Metabolism guidelines recommend 2 to 1.6 grams of protein per kilogram of body weight per day for active older adults. Critically, the distribution matters almost as much as the total. You need 25 to 40 grams per meal, not concentrated in one sitting, with particular attention to the post-exercise window within 2 hours of training. Eggs, fish, poultry, dairy, and legumes combined with grains are your highest utility sources. What to minimize? Refined sugars and ultra-processed foods activate the mTOR pathway in ways that promote cellular senescence. Excess alcohol causes mitochondrial damage and oxidative stress. Processed red meats elevate TMAO and systemic inflammation. These are not peripheral lifestyle suggestions. They directly feed the mechanisms we discussed. On the timing question, intermittent fasting and caloric restriction. Here is what the evidence actually shows. The calorie trial published by Avera and colleagues in Aging Cell in 2024 is the most rigorous human study on this topic. It was a randomized controlled trial. The highest level of evidence involving healthy non-obese adults maintained an approximately 25% caloric restriction for 24 months. The result: significant reduction in circulating biomarkers of cellular senescence compared to the adividium eating control group. This is the most robust human evidence we have that reducing the ambient toxic load from senescent cells is achievable through diet in real people. The practical translation, given that 25% sustained caloric restriction is difficult and comes with risks I'll address in a moment, is time-restricted eating. Confining your eating to an 8 to 10 hour window. First meal at 10 a.m., last meal by 6 or 7 p.m., for example, achieve some of the same metabolic signaling as caloric restriction with more realistic adherence. The MIT Yilmaz lab published data in Nature in 2024 showing that the refeeding phase following a fast is when intestinal stem cells show peak proliferative activity, meaning the cycle of fasting and eating, not just the fasting itself, appears to be biologically meaningful. Now the safety parameters, which I need to be unambiguous about. Intermittent fasting is contraindicated. It is not appropriate for people with type 1 diabetes or type 2 diabetes managed with insulin or solailus like lenalidomide or glipizide. The risk of hypoglycemia is real and serious. If you take metformin, extended fasting beyond 24 hours carries risk of lactic acidosis. Anyone with a history of an eating disorder should not pursue caloric restriction or fasting protocols. Adults with a BMI below 20, significant and intentional weight loss or severe sarcopenia. This is not for you. If you have advanced chronic kidney disease, protein restriction is a separate concern that your nephrologist needs to manage. Please, if any of these apply to you, take this information to your physician rather than acting on it alone. The third pillar is sleep, and I think it is the most underestimated lever in this entire conversation. A 2022 review in Science Direct established that circadian rhythm disruption is a major mechanism of stem cell aging. The circadian clock, the internal 24-hour timer that regulates nearly every cellular process, directly governs the quiescence and activation cycles of stem cells across multiple tissue types. When that clock runs poorly, stem cell function degrades. Multiple studies have associated sleep under 6 hours with elevated SAS expression and accelerated cellular senescence. The protocol here is not complicated, but adherence is genuinely difficult for many older adults because sleep architecture changes with age. 7 to 10 hours of sleep per night at consistent times, 7 days a week, not 5 nights on schedule and 2 nights off matters. The consistency appears to be as important as the duration. A dark, cool sleeping environment around 18 to 20 degrees C supports the drop in core body temperature that triggers deep sleep stages. Screens off an hour before bed. And one practice that is underutilized, 15 to 20 minutes of natural morning light exposure within the first hour of waking. This morning light signal is one of the most powerful inputs for resetting the circadian clock, and by extension for keeping the rhythmic regulation of stem cell activity on track. The fourth pillar is stress management, and I raise it because the mechanism is generally biological, not motivational. Chronic psychological stress elevates cortisol, which chronically activates pro-inflammatory signaling pathways. The downstream effect is accelerated accumulation of senescent cells and elevated SASP, the same mechanism we discussed in the first section. Studies of mindfulness-based stress reduction have demonstrated measurable reductions in IL-6 and TNF-alpha, the primary sappy cytokines in older adults. Social isolation is one of the most potent activators of inflammation we know of. The biological effect of chronic loneliness on inflammatory markers is comparable to smoking approximately 15 cigarettes a day. According to population data, 10 to 20 minutes of daily meditation or breath work, particularly diaphragmatic breathing with extended exhalation, has a documented effect on the autonomic nervous system that reduces the cortisol inflammatory cascade. Regular social engagement is not a soft recommendation. It is a direct intervention on the inflammatory biology of stem cell aging. Time in natural environments shows growing evidence of cortisol and IL-6 reduction. These are not peripheral lifestyle amenities. They address mechanism 4 and 5 directly. The fifth pillar is targeted supplementation. And here I want to be more careful than most health content tends to be, because the gap between what is sold in this space and what the evidence actually supports is large. The supplements with the most legitimate evidence relevant to this topic are 3. Vitamin D3, omega-3 fatty acids, and quercetin from dietary sources. Vitamin D3 deficiency, defined as serum 25-HD below 30 nanox per milliliter, is extremely common in adults over 50, particularly those living at higher latitudes or spending limited time outdoors. Deficiency is associated with accelerated immune senescence and impaired stem cell function. Before supplementing, get your level tested. The target range supported by the research is 40 to 60 nanox per milliliter serum 25D. Supplemental doses in the range of 1,000 to 4,000 IU daily are typically needed to reach and maintain that range depending on your baseline. Combine it with vitamin K2 in the MK7 form if you are supplementing at the higher end, as K2 helps direct calcium appropriately. One important interaction: if you take thiacid diuretics, high-dose vitamin D3 raises the risk of hypercalcemia. Your physician needs to know. Omega-3 fatty acids at 2 to 4 grams daily of combined EPA and DHA directly reduce IL-6 and TNF-alpha. And some studies show telomere preservation at consistent intake. If you eat fatty fish twice or more per week, your dietary intake may be sufficient. If not, a quality fish oil or algae-based omega-3 supplement achieves the same endpoint. At doses above 3 grams daily, inform your physician if you take any anticoagulants, as there is a meaningful interaction affecting bleeding risk on quercetin as a supplement. I need to draw a clear line here. The clinical evidence for senolytics involved the satinib combined with quetine, not quetiapine alone. Quetiapine in isolation has not demonstrated significant senolytic effect in randomized controlled trials. The doses used in research were 500 to 1, 250 ml per day in short cycles. Quercetin from food sources: capers, red onions, apples provides meaningful polyphenol intake without the interaction risks. If you take warfarin or acenocameral, quercetin supplements interact and can elevate your INR. If you take cyclosporin or tacrolimus, there's an immunosuppressant interaction. If you have hypothyroidism, there's a potential interference with thyroid hormone absorption. The satinib itself I will not discuss as a self-administered option. It is a chemotherapy agent requiring oncology oversight and strict monitoring of hepatic and renal function. It is what researchers are studying, not what you should be sourcing on your own. MN and NA, the NAD precursors, deserve a brief mention because they generate enormous commercial interest. NANDO does decline with age. Elerating it improves mitochondrial function, including in stem cells in animal models. Human RCTs have demonstrated safety and some metabolic benefits. There is not yet an RCT demonstrating stem cell activation in humans. If you're considering them, they are expensive. And if you take diabetes medications, the improvement in insulin sensitivity that sometimes occurs may require medication adjustment. Your doctor should know. If you have any history of cancer, discuss this with your oncologist before starting. Now, let me talk about what to expect from these interventions in realistic terms. Because the most common mistake I see is expecting immediate dramatic change and then abandoning an effective protocol because it didn't feel like anything happened in the first 2 weeks. In weeks 1 and 2, the changes are largely invisible but real. If you're implementing consistent sleep and the dietary pattern, most people notice modestly improved energy and sleep quality. These are subjective, but they reflect the early reduction in inflammatory burden. At the 1-month mark, inflammatory biomarkers, specifically high-sensitivity CRP and IL-6, if you get them measured, typically begin to decline in response to consistent exercise and dietary change.